All right. Now here we have little interruption from the internet, and also the technical issue always it is it comes whenever we least expect. So here we have, and sorry for starting it late, and myself Dr. Rohini, and I'm a medico at Kasturba Medical College, and it is from a deemed university. This is Mahe, Manipal Academy of Higher Education, so which has some finest universities. This is the finest universities, and it has some very nice colleges associated with it. So one of them is this Kasturba Medical College at Mangalore location. So there is one more at Manipal, which also has very nice museum. It is considered to be one of the best museums in the global museum, anatomy museum. So now here there is some more additional qualifications which I want to list, like I have a medical transcription degree, MBA from in hospital administration, that's from USA. And I also have the PhD from Savita University, Chennai. And I also have the embryologist certification codes. And this is called the ART, Assisted Reproductive Technique. All right, so these are some of the things. And I also have a lot of experience in teaching and also counseling. So this is my referral code. You can see my referral code, which is very useful when you want to access the free products, including those special classes, quizzes, tests, etc. You should look for this, referral code. All right, let me see if there is anyone who is still having trouble accessing my classes. All right. I would urge each and everyone to subscribe so that you will be able to chat with me during the session. So only those who have subscribed will be able to chat. So please go ahead and subscribe, and it will be really, really useful for you. You also it is fine. Okay, let's start with the first one. Let's not waste any more time. Let's start with the just first one. Okay, now here there is a question. It says a muscle which flexes both hip and knee joints is. Now, there are so many flexors, so many extensors. Now, let's make it very simple. There are quadriceps, right, in the thigh region. So, we are talking about the thigh region, and these are the ones which are going to act on the knee. So, we have the thigh region, we have quadriceps, and we have the hamstrings. And here you must remember quadriceps are the ones deal with the extension aspect, extension of the knee. Hamstrings are the one which are flexors of the knee. If there is a muscle that crosses two joints, for example, the one which crosses both the hip joint as well as the knee joint. So think of that muscle. Now here there is one more muscle in the upper limb as well. That is the biceps. Okay, biceps also crosses the shoulder joint, and also it crosses the elbow joint. So here what happens? It acts on both of them. But always the action is better where there is insertion. Action is good where there is insertion. So you think, where is the insertion? It starts from one end and the insertion is on the other end. So it crosses the second joint to have the insertion. It has to cross the elbow joint. So biceps would act better on the elbow joint. All right. So similarly, now think of the hamstrings. Now here you have hamstrings and think of the quadriceps. Now the question is a muscle which flexes both hip and knee joint is. Now which one is the flexor of hip as well as the knee joint? Now what about gluteus maximus? Is it a flexor? We're talking only about flexion. We are not talking about extension. So is it a flexor? It is not a flexor, it is a extensor. So this is ruled out. So this is not the answer, that is ruled out. If there is anyone who is answering, it would be really nice to relate. Yes, rectus femoris cross joint. Ruvula Nileshwari has been talking and she says rectus femoris crosses hip joint and the knee joint. We'll talk about it. But that is an extensor again. So we are talking about flexors, dear. Now, biceps femoris. What is biceps femoris? Biceps femoris is on the hamstring section. So now this is hamstring. So this is also flexor. But this flexes only the knee. Next, we have rectus femoris. This is a extensor because it is in the quadriceps group. Okay, that's an extensor. So we have another one which crosses both the joints and also does flexion of the hip, and also to some extent it can flex the knee joint. Okay, so remember Nikhileshwari. Yes, I got your name right, Nikhileshwari. It is the sartorius muscle, which is, from the anterior superior iliac spine. Anterior superior iliac spine. It has a weird, course. The 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 muscle is not straight. The muscle neither it is short nor it is straight. It has a weird course and it is also merging with the fibers of another muscle. Let's see what it is. Okay, so here is the sartorius. This one is sartorius. Let me just mark it little more, with the brighter color. So this is sartorius. Okay, longest muscle, yes. And you can also see it is from the anterior superior iliac spine along with one more muscle. You can also see this tensor fascial lata. That also comes from the same direction, okay? So along with that, plus there is a ligament. That ligament is called the inguinal ligament. You can see all these three are together. The inguinal ligament, the sartorius, and the tensor fascial lata. So this is the anterior superior iliac spine. So all of them, like three different, you have seen the fan blades, it go in three different directions. Like that, they have just popped out from one origin and gone into three different directions. So you can see the inguinal ligament. It's also called the Paupat ligament. And you can see the sartorius, but it goes to the medial aspect. Okay, so this is the one which flexes. It goes to the back side and it goes to the medial aspect along with the semitendinosus and semimembranosus. It takes the insertion. It crosses the joint. That's the reason it has action on both the joints. It's not only flexes the hip, but it also helps in flexion of the knee. Okay. So Murali Niveti, yes, you are also right. The answer is D, Sartorius. Okay, so next one we have, let's see the next one. So here we have other muscles also. Once you remove this rectus, you can also see those bulky vastus muscles. You can see the vastus medialis, you can see the lateralis, and you can also see the intermedius. So all this bulky muscle is the quadratus or quadriceps group, not quadratus, quadriceps group muscles. Okay, you can also notice one more thing, that is the adductor canal. Okay, once you remove this sartorius, you should be able to see the adductor canal. Why? Because it is right below it. That is called subsartorial. That's why. Subsartorial is below. That's why once you remove the sartorius, you can see the adductor canal, and you can see how beautifully the femoral artery and the vein is passing through it. Both of them you can see, right? Okay, next let's move on to the next one. So here we have the answer for this. We are going a little slow because I want you to understand this thoroughly so that there is absolutely no question that is left in your head. So I want you to understand the answer properly so that you don't have to go back to the same topic over and over again. So we have the function of the sartorius is unique because it can serve as both the hip and the knee flexor. The origin of the sartorius is same as the inguinal ligament and also the tensor fasciolata that you can see. And it not only does the flexion, but it also acts as the external rotator of the hip. So along with the other muscles, we have some external rotators of the or lateral rotators of the hip. There are 6 of them. Along with that, the sartorius also does the action. So we have very nice, action by this. Yes, we have interaction from MXSTR. I don't know how to pronounce that name, but yeah, we'll call it as MX. And we have Murli and we have Nikhileshwari. All right. So this muscle plays an important role in stabilization of the pelvis also, especially in case of women. The stabilization of the pelvis, okay, is maintained by the sartorius. So keep that in mind. Next one, next question. Let's go to the next question. Let's see what this has to say. Which of the following structures is likely to get damaged when semi-flexed knee is suddenly rotated medially? So now always there is locking and unlocking, correct? There is an action called, I'll put the locking first. Why unlock? Always locked, locked knee. That is when the tibia turns over the femur. Tibia is the one which turns over the femur, turns medially over the femur. That is when it is locked knee. And it happens automatically, right? Automatically when you hyperextend. And there is another action called unlock. And unlocking is done by popliteus muscle. And one more thing I want to mention is unlocking is the first step to flexion. So unless you unlock your knee, you cannot flex your knee. So that is the first step to flexion. Remember that. There is so many ligaments. There is anterior cruciate ligament in the knee. There is posterior cruciate ligament. There is lateral meniscus and there is medial meniscus. So these are the structures that are present within the joint cavity. Now you tell me which one can get damaged when the knee is suddenly rotated medially. It is rotated medially, just like you are trying to lock your knee. Suddenly you have tried to rotate the knee, and that too in a semi-flexed position, because you cannot lock when your knee is semi-flexed. You have to extend the knee and only then you have to lock, right? It's just like close the door and then lock it. Without closing the door, you cannot lock it. Just like that, knee also has to be medially rotated and then you can lock it. But here the knee is flexed. So how can you lock it? So here the answer is, what do you think is the answer? Anterior cruciate ligament, does it come into picture? No, it is right in the center between the two menisci. There is right and left menisci. Between that, in the gap, there is this cruciate ligaments and there is menisci. Menisci is not actually the ligaments. They are not the cartilages. They are the small pack of, white fibro cartilage. So menisci is like a disc that is placed within the joint cavity to separate the joint cavity. So now here you have medial menisci and lateral menisci. Let's see where exactly it is. So this is the one. This is the medial menisci, and we have the lateral menisci. And one thing you can notice is lateral meniscus is nowhere close to this lateral collateral ligament, whereas the medial menisci is very close to the collateral ligament. See this portion. See here how close it is. So very closely it is associated with the. So whenever there is a damage to the medial collateral ligament, there is always damage to the medial menisci because it is attached to it. So since it is attached to it, there is always a damage. Now, what is the question? So now there is always damage to the semi-flexed knee is suddenly medially rotated. So when you medially rotate in this direction, when this tibia turns medially in this direction, it can always damage the medial meniscus, not the lateral meniscus. That is the thing. So this is the anterior cruciate. You can also see the posterior cruciate ligament. And when do you turn it medially? When you want to lock it. So there is always chance that medial meniscus can get damaged. That is one important thing to note down. All right. So now here we have some nice, messages. I wanted to update this, but because of the little time constraint, I could not do it in time. And I have some more dedications from the students, which I definitely want to post it here. And because that is something that makes me feel proud. And I really, really very thankful to all those who have been really generous in accepting our classes and really liking those classes and also appreciating it in the form, in the verbal form. So that is something that is really motivating. So here we have blue hat given to Dr. SK, that is for dedicated 1,000 minutes he has given. And we have orange hat for Faisal. And he has also got some nice words to say. Let's see what it is. You can go to my profile and see what the words are. All right, so here we have, and then we have the profile where you can see all my credentials, you can see, and you can see the number of followers. Of course, don't go by this number of followers because it is already doubled. So this has been doubled, and I'm very, very happy to say that this has been doubled only because of the students and dedicated students who are so dedicated to their subject, and it is all because of you. And here is my profile. I'm the educator number 48 now, not 49, 48. I'm going up the ladder. That is also because of you. And you can see my profile, read up all this, and also just see the freebies that I have put up. There are so many tests and quizzes that you can access. Please go ahead and see, but you need to use the referral code when you want to access anything. So it is ROHINI. You can also use this referral code ROHINI 10. So please use this referral code wherever prompted and take the freebies. So here we have red hat, we have yellow hat, and all these are by the students. So special classes, what is so special about special classes? We have YouTube classes, of course, but the special classes are very different from these because you have more interaction. So in YouTube classes, you feel like a small fish in the big pond. YouTube, so many things are going on, and you are interested in some particular topic that may just get lost, right? Next day, you have to go back to history, search for the topic, and sometimes it becomes very difficult also to get it aligned in a proper manner. But it is not so in the case of special classes. Why? Because you have subscribed. Okay, this is one thing. When you subscribe, you are part of the Unacademy. You get a notification for every class. You never miss a class. So it is a big motivation. We give you study to achieve your own goal. Okay. And that is never miss a class. And when you subscribe, when you have a playlist of all the classes, where is the question of missing a class? Where is the question of feeling left out? Because you are invited for the class with the note saying that the class is about to start, please join. So you are invited. It is a classroom and you are part of the classroom, and it is very interactive like class, and it is structured, and you also have polls for the learners where we can answer the MCQs. You feel nice whenever you are picked as one of the person who has answered it right. And there is also a feature, raise a hand, where you can raise your hand and give your answer. There are also lecture notes available at the end of the class, which you can download, and anytime, anywhere you can access. This is another feature, because you are not confined to just one place where you are supposed to access it. You can answer it, access it anytime. So you can play it multiple times and see, also learn lots from them. And so please go ahead, subscribe to Unacademy, and you have to download the app for this. What is the app? That is called the Learners app from Unacademy. You know the logo, Unacademy logo. So go there, download the app, and then go to straight away NEET PG section. This is for all you guys, I'm telling you. Go to the NEET PG section, look for the educator. For example, look for me. Who am I? I'm Rohini YN. You can also look for me under the username ROHAQUA. Okay, when you do so, you will get to access all my classes, and you will get all the schedule of my classes. So you also have upcoming recorded special classes. That is, tonight I have a class. I have a class at 10 o'clock, and I also have at 11 o'clock. Both are very interesting. One is about the nasal cavity. We are going to discuss a lot of things about the nasal cavity with the MCQs. So let's go ahead and do that at 10 p.m. And then we also have image-based learning. Image-based, we have a lot of cadaveric images and other images, which is going to be interesting, because at this hour, 11 p.m., sometimes we don't want to look at the words. We want more of images. So that's what we have at 11 p.m. So learning never stops, be it daytime or nighttime, right? This is all coming up in the special class tonight at 10 p.m. and 11 p.m. So here you have plus subscription, and plus subscription is for access both live and recorded classes. You can go with complete live in test and quizzes and many more things. You can study from your device itself. So you don't need a laptop. So Iconic is something little more advanced, where you also have the PrepLadder with it. So Unacademy and PrepLadder is clubbed together. So it is a different best of, two different platforms you can access. You also have parallelly running courses like Focus FMG that started on 4th of August. Just today it started. So you also get PDF notes for the session. You also get recorded, lot of recorded things you get. You also have doubt clearing sessions here. You can take up that. And you also have Target Next 2022, where you have January to, June to January evening sessions. That is starting just today, 4th August. So here also you can have the PDF notes. So all these are something that is very, very interesting. So you can see NEET PG test and analysis we have, where it also started on 4th. So today is the day for everything. So please go ahead and see what all, interests you and what fits into your kind of study method. And you also have 19 subjects covered by various staff. And you also have the ultra fast track high yield topic revision, you have exams coming up and you want to revise at least 3 hours a day, so go ahead with Unacademy and you can do that. And 19 subjects are covered within no time. And you also have test series coming up that is scheduled from 31st July. We have started. It's going on till 9th of September, till your exams. So if you have studied and you're looking for some revision, go with this. And you have 4 year subscription introducing only plus subscription is 60 and iconic is 75. This is for all those who are in UG, want to have a firm basis for their PG preparations. So this is what you should go with it. Then we also have launched 6750 only with the plus subscription. So here launching 2 month subscription, and that is just 6750 instead of 7500. And here we also have 2 month subscription here, the same thing, and you can use the code. That is something you should never forget. Code is for you to gain some, uh, discount. So you can avail discount up to 10%. Go with that. And you have a limited time offer when you go for those monthly 36 months. From 92 to 58, it has been slashed. So here also 10% discount is applicable. Then here you have 24, 18, 12, etc. Please use the code wherever prompted. Okay. So we have a price hike from August 5th. So the price hike is something that is, important to note, because all this time you had a different price. So you don't want that to be hiked. That is the last day. Today is the last day. So you still have time. You still have many, many hours left. You can go with the subscription, Unacademy and PrepLadder access. Both you will get. And that is for the iconic subscription. And after the price is hiked, it will not drop down because we have a lot of people who want to take it up. And last day is today. So don't waste any more time. Go with the subscription. And here we have another feature, raise a hand. What is this? This, you can see that there is a small icon with a hand, and that indicates that the students can interact with the educators, and you can interact in the form of questions. You can clarify your doubts, everything during the live class. And others also are benefited because they too get to hear and understand what your question was, and all that is answered. And last mile to NEET PG from July 16th, it started. For 2 months it's going to go on. We have all the educators. I have just covered my anatomy, and I have some more happening this month, and about 14 to 15 hours is put up in these classes. So don't ignore any of these. Please go thoroughly see what they are all about and see what will be, best fitting for your kind of curriculum, and go ahead and subscribe. And we also have integrated clinical batch. We also have clinical batch with MCQs that we have. Then there is focus FMG batch that also started on 21st. And we have the iconic and the plus subscriptions where we have 48 months is for 1125 only per month. And here we have 48 months is 1406 per month. There is a little difference in the price, right? And you can see that all this is with the code. Don't forget the code ever. It is ROHINI. So use the code and get the plus or the iconic subscription. Okay, so we have all this for those who have been patiently watching. A big thank you from my side. This is the referral code I was talking about. And don't forget to subscribe and like all my classes. And also please follow me. I'm Dr. Rohini Vayan. So there are many students who are new to me because INICT and FMG, I have not met the students. If you are one of those, please watch my classes and see how much interest you can develop with my classes. Okay, and next, moving on to the next one. Dear students, Trendelenburg test is positive. When do you think it is positive? In what following conditions or what, a condition, it is not positive, it is considered to be negative. So there are so many cases where it is considered to be positive. Now, first of all, Trendelenburg test is for what? For what are we going to check the test? This test is for anybody, anyone typing in the answers? Anyone typing in the answer? Trendelenburg test. It is for those, anyone? Abductors. Abductors of which one? Abductors of the hip. Angelo, MX, Murli, hip abductor. So we have gluteus medius, gluteus minimus, both of them. These two are the abductors of the hip, right? What are they supplied by? They are supplied by the superior gluteal nerve. All these gluteal nerves, superior and inferior gluteal nerves are supplied, or all the branches of which one? Vessels, superior gluteal, inferior gluteal. Okay, they're all from the plexus, and we also have the vessels from the internal iliac. Iliac gives all those vessels. So now here, in what condition it is considered to be negative? So test is positive in the following conditions, except dislocation of the hip. What happens to that? Is a person able to lift his foot off the ground? Is a question. Fracture of the neck of the femur. Paralysis of gluteus medius. Paralysis of gluteus maximus. In all these conditions, he is not able to lift off the ground. What about gluteus maximus? Yes, he is still able to lift it off the ground. So, Rocky, think over. What do you think is the action? Paralysis of, I would say, paralysis of gluteus maximus. Let's see. You have to find the one which is except. I think you're going with the different answer. You have to look for the except word. Keyword you have to keep in mind when you look for your answer. So the answer here is D. Like I said, it was the Trendelenburg sign. First of all, what is it? Now here it is found in people with the weak or paralyzed abductor muscles. Now we have gluteus medius and minimus as the abductors of the hip joint. And then you can see that the negative Trendelen, this is the negative. Why? Because he is able to keep it off the ground. And the hip abductors are acting normally and tilting the pelvis. So you see the tilting of the pelvis on the opposite side. The pelvis is tilted the opposite side here. When the opposite leg is raised from the ground. Why? Because to balance your body, it is tilted on the opposite side. But here what has happened? The Trendelenburg is positive because the hip abductors are not able to help in tilting the hip on the opposite side. So they are not doing their job. So that's why we have the positive sign. Now we have to find the one which are all negatives. So in all these cases, it will come as the negative. So here only in this case, it will come as positive. So now next one, let's go to the next one. Fourth one, gyrus occupying, gyrus occupying. So go with this question. Let's see whether you know any neuroanatomy. How many of you know neuroanatomy well? Neuroanatomy, I have a whole lot of topics that has been, taught in the previous month. I have all those covered. We have a lot more coming in this month as well. We will go ahead with all that neuroanatomy sessions and MCQs. So you have to message me what exactly you are looking for. Just you are in your last leg to your preparation. You have to tell me what exactly you're looking for. So then I'll be able to incorporate all that you are missing from your villa. All right. So we have gyrus occupying Broca's speech area. What is gyrus? That is part of the cerebral hemisphere, the elevations, and we have a lot of these things. So these elevations are the gyri. This is the sulci. So we're talking about the gyri. We have so many areas on those gyri, right? They're functional areas, they're called. So we have functional areas in different places. We'll go about seeing all those functional areas, but gyri occupying the Broca speech area. Where is the speech area? Is it in the frontal? Frontal, what do we have? We have the eye field. We don't have that. We have the eye field, especially area number 8 is very important here. Then middle frontal, what do we have? We have all these associated with the, parietal. So we have pre-parietal. So we have the motor area, sensory areas. Next, we have inferior frontal. Is it the one or superior frontal? Now, where is the Broca's speech area? So is this the one or is this the one? Let's see which one it is. It is answer C. So here is the inferior frontal part of the frontal gyrus. So superior temporal, no. So temporal is here below this. The lateral sulcus, this is the lateral sulcus. Below that is the temporal. Temporal, we have mainly the auditory. That is the area number 42. We also have vernix area. That is area number, 40. Broca's speech area, this is 22. We have this one in the inferior part of frontal. Okay, so we have, this is the motor area. We have the sensory area in the parietal. So this is the central sulcus. This is called the precentral gyrus. Here we have 3, 2, 1 functional area. All right, so now let's see what is Broca's speech area and what is vernix area. What is the difference between these two? It's very, very important to know what both the areas mean. And there is called Broca's aphasia and vernix aphasia. Now, exactly what is wrong in Broca's and what is wrong in vernix? What goes wrong in Broca's and what goes wrong in vernix? So here you remember BMF, okay, all this B, remember the B is non-fluent, okay. Only Broca's if you have to take up, you please remember it is motor. It is just like, okay, this is in the Broca's, M is for motor and F is for frontal. You remember this one, and it is non-fluent. What does that mean? That means the words are itself broken. It is very difficult to understand the words because he may be making sense, but the thing is sense, yes, makes sense. Of course, for the person who understands, it makes sense, but the words are broken. So it is very difficult to put the words together and then make it a sense. Okay, bad mother, don't go by this one. Let's not use this. Okay. Broca motor frontal. Okay, so now we have that's the reason I gave you this BMF. So please use this BMF and you will be able to get all these three things. There is no better mnemonic than this, if that is what you are going to use. Then you have Vernix. Vernix, what happens? Here there is very much fluency in talk. So the person speaks very fluently, but he speaks so fast and it makes very little sense of what he is telling. So very little sense. Remember wacky words. W for wacky words or word salad. So that means the words that are picked are not at all making sense. He is very fluent. He is talking without any break. And for the person who is listening, he feels that whatever he is talking doesn't make any sense. And speech is normal and excessive, but makes little sense. So this is what you have to remember. And where is this one? This one is in the temporal lobe, and that one is in the frontal lobe. And what about vernix? It is sensory, and this one is mainly motor. So this is the difference between the Broca's speech area and vernix area. It's very important. Next one. So what is vernix aphasia? There is Broca's aphasia and vernix aphasia. That is fluent, but it is complete nonsense. Like I said, W for wacky. Wacky is something that doesn't make any sense. Okay, so language comprehension in heard speech, all this. So grammar and syntax are adequate, but the ability to appropriately link the speech, he may not be, just like new language, he may not be picking the right words in right place, and the entire sentence becomes a nonsense sentence. So now here Broca's and vernix, you can see I said, remember DMF, Broca's, motor and frontal. Remember the opposite for this, W, M is here, so sensory, and F is here, this is temporal. So you remember this as wacky. So that itself should tell you the speech is fine, your speech is broken, or disordered grammar, disordered syntax, comprehension is intact, comprehension is what? Impaired. Okay, so remember these two things. And this is the area number 45, 44, and this is 22. So keep this in mind. And here will be another one, auditory area also. That is also associated with the Broca's. That is also 44, auditory area, the temporal. So all these are interrelated. That's why we call deaf and dumb together, right? Why? Because the person who cannot hear will also have the Broca's aphasia. Next one. In midbrain, foreign structures are found at the level of oculomotor nerve. So there are various sections taken at the level of midbrain. So we have, at the level of superior colliculus, at the level of inferior colliculus, all these sections are taken. At these levels, whenever it is taken, you have the red nucleus. The function of the red nucleus is completely unknown. Okay, the function of red nucleus is unknown actually. So we have the picture here. Answer is decussation of superior cerebellar peduncle. So we have pretectal nucleus, substantia nigra, decussation of superior cerebellar peduncle. So now let's see, not the red nucleus, sorry. Stop the question. Here we have, let's see this. So we have the oculomotor, we have the red nucleus, and we also have the cerebellar peduncles. So we have superior, middle, and the inferior cerebellar peduncles. You can also see the aqueduct, cerebral aqueduct you can see. You can also see the red nucleus, and of course you can see the red nucleus. You can see the substantia nigra. Okay. Why you call this diagram? Because it is the dark black spots. That's why. You can see the oculomotor pathway also. Then you can see crus cerebri, that is the superior peduncle. So I wasn't wrong. There are two answers actually which you can pick, the superior peduncle as well as the red nucleus. So both are correct. So sometimes you will be taken by surprise that sometimes the question has two options to pick, but probably they wanted you to answer in terms of the peduncle, not in terms of the nuclei. Okay, next one. The following are all the features of the cerebellar lesion. So think of all those lesions that happen. What is the function of cerebellum and what are those nuclei that are present in the cerebellum? I would say I have a nice, mnemonic. Don't eat fatty. Don't eat greasy food actually. We have D, dentate, emboliform, globus, and fastigial. Okay, so pardon the sound. And then we have following are all the features of cerebellar lesions except which one is not part of this lesion. So let's see what are the lesions first of all. Does this dysdiadocholine, dysdiadocholine, does this come into the picture? Nystagmus, does it come into the picture? Rigidity of voluntary muscle. See, one thing you should remember, there is tremor always. There is tremor. Why would the rigidity come? That is opposite of the tremor. That is one thing. There is intention tremor. Yes, because of the decreased dopamine, right? So now here we have cerebellar lesions. Scanning speech. You remember this one? Sin, you remember. Scanning speech, intention tremor, and nystagmus. These see, and then you can see triple A, athenia, ataxia, atonia. So these are the three things, the joints and gait and the speech. All the three are impaired. And then there is D's. 4 D's are there. 3 A's and PRV or PVR. I would remember it as PVR theaters. So I would remember it as PVRs. Okay, you have D, dysdiadokinesia, you have dysmetria, decomposition of the movement, and drunken gait. Okay, shuffling gait you have. And you have the other three, pendular knee jerk, rebound phenomenon, and also vertigo, because it is associated with the cranial nerve, the eighth cranial nerve. Okay, it is associated with the inner ear. Which node? The flocculonodular lobe. That's why. That is associated with the equilibrium. Hence, there is also vertigo. So these are the signs of cerebellar lesion. Did you see anything that says rigidity? No. Absolutely, there is no rigidity. There is, in fact, there is more movement, that is called tremors. So you have, there is increased movement. There is no control over the movement. That is what happens in cerebellar lesions. But here, one of the option was the rigidity. So this is wrong. This is not nothing to do with the cerebellar lesion. So this is something you need to fix. So here, the answer was rigidity of voluntary muscles. Okay, next one. Seventh one. The seventh one says the nerve having Edinger-Westphal nucleus as its component. Now, Edinger-Westphal nucleus, you should remember where it is and at what level. So which nuclei is at what level? If you remember, at the brainstem, what nuclei are present? At the level of midbrain, what nuclei? And if you know which nerve comes from which direction and from which area, then you will be able to relate the nerve with the nuclei. Okay, all these cranial nerves emerge from these nuclei. So we have oculomotor, that is the third one. We have the trochlea, and then we have the trigeminal, fifth one, and then we have the abducent, the sixth one. Let's see all this. There is the oculomotor, then we have trochlear, trigeminal, abducent. Okay. Where is abducent? This is the junction, the pontomedullary junction. And trigeminal, this is at the level of pons. This is from the dorsal aspect of the pons. And this is the only one at the level of mid. And that is exactly where we have this Edinger-Westphal nucleus. So let's see whether I'm right. So we have here, we have the first one, olfactory. So that is no nuclei. Then you have the second one, no, not associated with any nuclei. So keep this in mind, okay? Keep this in mind. And here what we have, olfactory epithelium, the function is smell. And then we have, this is SSA, special somatic afferent. So retina of the eyeball, and you have the vision. So these are all special. So remember, S is for special. So this is special sense. Eye and nose is special sense. And then we have the SE, effector. So this is the effector. So we have oculomotor nucleus, and this is for the effector is always for either muscles or gland. Okay, the one which ends with E is always for, you just watch the pattern. It's always for a muscle or a gland. Okay, so you have GVE, general visceral efferent. Okay, so we have this constriction of pupil, accommodation, all that. That is Edinger-Westphal nucleus. So we have the third one, oculomotor, and also from the Edinger-Westphal nucleus. So you remember this one. So this is what we are looking at. Okay, the third cranial nerve is associated with the nuclei, Edinger-Westphal nuclei. Okay, and also with the oculomotor nucleus. And then we have the fourth one, that is trochlear. Trochlear is efferent. I told you efferent is for the muscle. So you please see the movement of the eyeball, and it is for the muscle. And then I said again E will end in again some muscle. Okay, muscles of mastication. That is SVE, visceral, some muscle or a gland. Again GSA, afferent. So now this is something going towards the brain. So it is touch and pain, temperature, all this sensation is carried to the brain. So it is afferent to brain. These are all afferents. Ending with E are all efferent to the effector organ. So here we have E, E, E. This is A. This is A. This is A. So hearing is going to the brain. Okay. This one, skin to the brain. Taste going to the brain. So these are all to the brain. To brain. To brain. I hope you are understanding. E is to the effector organ. This is to the effector organ. So where is the effector organ? Here we have a muscle, lateral rectus, and we have GVE. I told you it should be a gland. So here you have the gland. You have the submandibular and sublingual gland. And GVE, again, muscles of facial expression. When I say V, it is, I said visceral, it has to be some muscle. Now, GVE. So all these muscles of facial expression, and the function, elevation of the hyoid bone, etc. So when elevation of the hyoid bone happens, The muscles of facial expression, elevation of the hyoid bone, all this you have to remember that is associated with the seventh cranial nerve. Supplying muscles, all those will do this such action. So this is a nice chart which gives you a hands-on, practice for what is afferent, what is efferent, and what functional components are there in which nerve, okay, cranial nerve we are talking about, and what nuclei is associated with. And quickly you can also show, go through what distribution and what is the function of those muscles or glands or wherever it is distributed. All that you can see. Correct? It's so beautiful it is. Next you have the eighth question, pharyngotympanic tube. What is this pharyngotympanic tube? It connects the middle ear cavity with what? The name itself tells you, right? Pharynx. Tympanic, we know, ear. But which part of the pharynx? We have oropharynx, we have nasopharynx, and we have laryngopharynx. Does it open into the nasal cavity anywhere? As far as I know, you know, the air sinuses, they open into nasal cavity. It's called the lateral wall of nose. I have this particular session at 10 p.m. Please watch this lateral wall of the nose. I'm going to tell you about all those openings in the lateral wall of the nose, and we'll discuss more about this in the particular session. And here we have oropharynx, nasopharynx, laryngopharynx. So here pharyngotympanic tube connects the middle ear cavity with the, I would say, B, nasopharynx. So here you have the nasopharynx, and you also know that there is a small opening of the auditory tube in the nasal, nasopharynx. It is also has two folds, on either side, and in between that you have a depressed region that is called the opening of the auditory tube. So here it is the connection, and you can also see the bony projection you can see, and you see how closely the internal carotid artery is related. And you can also see the isthmus junction where the cartilaginous part and the bony part meet. And this is the nasopharynx. And you can also see that this is the eustachian tube that extends from the middle ear to the nasopharynx region. So middle ear to nasopharynx is its extension. So that is called pharyngotympanic tube. Let's see the next one. Only abductor of the vocal cords is. Now there are so many actions, right? In the vocal cords, there is tension happening. First, the vocal cord has to tense. You want to produce voice, it has to tense. Then there is adduction. Of course, there is abduction. And of course, whatever is tensed has to relax. So these are some of the movements you can see. Relax, tense, adduction and abduction. This is done exclusively by just one muscle. Only one muscle, okay? Abduction. And any damage to that results in nasal and monotonous voice. So which is that muscle? It is called the posterior cricoarytenoid. Let me just show you. All these are the adductors. This one is the tensor, and this one is the abductor. So the answer here is A. Let's see the answer. The answer is A. How did I pick A? I said there is only one muscle which abducts the vocal cord. So this is the adduction of the vocal cord. You can see this is the abduction of the cord. And this is the adduction. Adduction of the vocal cord will result this is because of the nerve. Which nerve supplies, that also depends on the, there is the external laryngeal and also there is recurrent laryngeal supplying. So vagus gives two branches. One is the superior laryngeal, which gives the external laryngeal and internal. Okay. And it also gives the recurrent laryngeal. So vagus branches are superior laryngeal and recurrent laryngeal. Superior laryngeal would supply, give two more branches, external and internal. Internal supplies all that mucosa and cells, that is sensory. There is external laryngeal which supplies only one muscle, that is cricothyroid. Cricothyroid. And recurrent laryngeal ends up supplying all the other muscles. The remaining 7 muscles. This is one muscle. So altogether we have 8 muscles forming the laryngeal group of muscles. So we have adductors, lateral cricoarytenoid, we have transverse arytenoid, and then we have abductor as only one, posterior cricoarytenoid, that you can see here, posterior cricoarytenoid. It's the abductor. Let's see here. The last question. Sensory nerve for upper lip is. Now, upper lip is supplied by. Sensory to the face itself is trigeminal, right? And motor is the facial. Sensory, trigeminal has 3 things. One is ophthalmic branch, maxillary branch, and mandibular branch. This goes to the lower jaw, lower lip. And this is what I'm thinking. This goes to the forehead region. This is purely for the muscles of facial expression. So let's see the sensory for upper lip is. Is it facial? No, I said it is for the muscles. Is it buccal? That is sensory to cheek area. External nasal? That is not on the upper lip. The name itself tells you. What about infraorbital? Okay, so the answer here is infraorbital. How did I conclude and say it is infraorbital? You have to learn to eliminate first. So, okay, it's not picking the right answer first. It is the eliminating first. So it's just like you have a big contest where you start eliminating the worst. So you have a singing competition. We do the same thing, right? We eliminate what is not good. So first you eliminate what is wrong. Then you have a less number of options to choose from. That becomes even more easy to, straight away pinpoint on the right one. If you have too many things in your mind, too many options, then that's what leads to confusion. So try to eliminate the wrong answer first. The worst answer, the wrong answers first. So we have here 3 branches: ophthalmic, maxillary, mandibular. So ophthalmic has the tip of the nose covered, the upper lid area, eyelid area, also the forehead region covered. This is all sensory I'm talking about. Remember, trigeminal sensory. We have the maxillary. It is a both actually. It is sensory plus the turbo. It is both actually, but this particular one is sensory, ophthalmic. So we have the maxillary, you have the upper lip area. That is what we want. We have the part of the side of the nose here. lower eyelid, also the cheek and temple region. So this is the maxillary. So you have to remember upper lip area is by the infraorbital. This is the infraorbital nerve. Infraorbital branch of nerve. Then you have mandibular zone. It includes the lower chin area, skin area, except this area which is supplied by the C1 root. That is greater auricular. What is that called? That is called angle of man. So don't forget that it is by greater auricular nerve. That is from C1 root. Okay, so I think we have reached the last slide where we are going to just, end it with a thank you note. And myself, Dr. Rohini Wayan, and I'm a NEET PG educator, and you can see me and you download that Unacademy app, Learners app. You can watch all my special classes. I have one at actually 10 p.m. and another one at 11 p.m. I have 2 hours non-stop. See, please catch me at this time. And I have two sessions. One is with the nasal cavity, another one is with loads of image-based MCQs. We are going to do something really nice today. Please see me at this time. And before that, if you don't have the app, download and also subscribe to my classes. And don't even forget to please hit a like on my page before you proceed. Thank you so much for watching and you have a good day.